A 60-year-old self-identified Hispanic man, a retired high school history teacher, presents to the emergency department with a 3-day history of sudden onset shaking, chills, high fever, and productive cough with thick, rust-colored sputum. All right, so let's go ahead and highlight this. So 3-day history, sudden onset, fever, cough, rust-colored sputum. All right, he also reports sharp right-sided chest pain that worsens with deep inspiration. He has a past medical history of mild osteoarthritis managed with over-the-counter acetaminophen, but has no chronic cardiopulmonary conditions or immunocompromising states. He denies recent travel, tobacco use, or known exposure to sick contacts. He did not, on physical exam, he appears acutely ill and tachypnic. His temperature is 102.4, heart rate is 104, respiratory rate is 24, and blood pressure is 120/74. Oxygen saturation is 93% on room air. On pulmonic exam, there is decreased red sounds, localized dullness to percussion, and coarse crackles over the right, middle, and lower lung fields. So it's pretty significant pulmonary exam finding. Increased tactile firmness and distinct bronchopnea are noted over the same area. The remainder of the physical examination is entirely normal. Chest radiograph demonstrates a dense lobar consolidation, completely filling the right radiograph, middle, and lower lobes. Okay, so we have a chest x-ray here that sort of confirms some kind of a consolidation. Which of the following pathogens is most likely to cause this patient's condition? All right, so let's work through what we think is going on here. So the diagnosis at this point should just be some kind of community-acquired pneumonia, but it's important to differentiate if there's some kind of a walking pneumonia, atypical pneumonia at hand here. But based on how acutely ill this patient's presenting, it's most likely going to be some kind of a community-acquired bacterial pneumonia. And so the important thing to remember here is the most common cause for that will be strep pneumoniae. And so that's why you can go directly to the answer. But it's worth discussing some of these other things here and some important pearls when it comes to pneumonia. So chlamydia pneumoniae is going to be one of the atypicals, as well as Legionella and Mycoplasma. The important distinguishing factor between these things is chlamydia is going to sort of present with more of a cough and pharyngitis kind of a picture. It might be a younger patient as well. And all these presentations are going to sound very similar. There's going to be cough involved, there's going to be headache, there's going to be some malaise, there's going to be fatigue. They're all going to sound very similar, but there's going to be some subtle differences. So Legionella is going to have a lot of GI symptoms involved, and they might also present with some hyponatremia. So on top of pneumonia, upper respiratory kind of a picture, you'll see some kind of GI symptoms. Mycoplasma is a little bit more subtle, but the chest x-ray findings will show patchy or diffuse infiltrates. Sometimes it will look worse than it actually is. So while it may present similar to the other two, that x-ray finding is somewhat specific for that Mycoplasma pneumoniae. So that sort of handles those three. Haemophilus influenza is going to also present sort of like these other ones, but this is going to have a more common presentation in patients with predisposed lung conditions, so COPD or any kind of emphysema. Those patients are going to be more susceptible to Haemophilus influenza. And so that's not what we have here. This is your classic community-acquired pneumonia, so E is the correct answer. Some important things to note, though, if you want to remember, if you see somebody who had a viral illness, something like just the flu, and they end up with some kind of pneumonia, the most common pathogen for that is going to be Staph aureus. If you are thinking of somebody that's very acutely ill, like this person, and there's already evidence of some kind of lobar consolidation, your answer most times is going to be strep pneumoniae. If there's, like I said, some kind of diffuse infiltrates and this presentation of some kind of upper respiratory thing going on that's maybe a couple weeks old, think of your atypicals, so chlamydia, Legionella, Mycoplasma, and then the specific features that I described for those above. And then this is also another important talking point about the pneumonia vaccine. So anyone over the age of 50 is supposed to be sort of eligible to get the vaccine for pneumonia, and it's typically those with other conditions, comorbidities, that would make them more sick. So somebody that has any kind of diabetes or immunosuppression, those would be the patients that are going to be eligible above the age of 50 to get this vaccine. And so typically you get these in a specific